not. Some people like to watch and listen afterwards, so we'll make a recording and then you can listen to it again if you want on our website, say a couple of days. Okay, so this is our sort of quarterly SHIBA Town Hall meeting program. I like to do these on the quarter just to check in with you all. As I said a moment ago, I really love doing these meeting conversations and look forward to the chance to have this dialogue with you. I appreciate a chance to hear from you directly about your experience of supporting the SHIBA program and make sure that we get your feedback about things that we're working on that we can do more or better or different to help support you in doing the work that you're doing. It's a very challenging assignment, I know that you have, and so I want to make sure that our support is aligned to your needs. And by no means is that a vote of no confidence in your volunteer coordinators, your RTCs, with other people that you work with in our team. It's just I want to be able to hear from you directly and for you to hear from me directly. And as ever, when we get to the last part of the program and I do sort of my future forecast, that's just one person's point of view. So for sure, there are other points of view about what's happening these days and what the future holds for us. But it feels like it's important for you to hear from me what I feel like the direction we're steering and why we're going that direction, why we're making some of the design decisions that we're making. If we haven't met before, by way of introduction, I'm Tim Smolin. I'm your SHIBA program manager. I've been on the job 5 years this month and love my job. Look forward to every day on the job, and working with you all was just such an honor and a privilege, and I'm just inspired by you every day. So my first purpose in doing these meetings, really sincerely, is just to thank you directly. I want you to hear directly from me how much I appreciate you. And of course, speaking for myself, but also on behalf of the agency leadership, we really appreciate you very much. And I want you to know that I see you and I care about you. And yeah, you're very important to me. So if you want to reach out, this is how you reach me. I'm always happy to hear from you. I'm generally pretty responsive. I'm slow getting back to Tina. But I'm better on email than phone. And please invite me to come visit. I always love to come out and see you all where you live and work, to work alongside of you, or to just join in your celebrations or kind of planning and problem solving work. So please, love to come out and visit you. And I do travel in the winter. I'm from the Midwest, so this weather is not even worth talking about as far as I'm concerned. But appreciate it. People love to talk about the weather. So today I'm going to do some quick staffing updates for you. I'm going to share with you my perspective about the year in review 2025 with a focus on Medicare open enrollment period, because obviously that's our surge of work here in the program. I want to do a preview for you about the business priorities that we have for the year ahead. And then, as I said, a little bit of future tripping about what I think might be coming next that we'll be reacting to or sort of steering towards or steering away from. But really, I want to make sure we have ample time for conversation. So I'm going to try to stop along the way and ask for feedback or questions. But if I don't, please feel just to shout out or raise your hand or drop a note in the chat. It's not meant to be me just yakking at you for 90 minutes. So let me start with staffing updates in our team. We're very excited to welcome into our team Callie and Millie. I didn't see that they were here, but let me just do a quick scan one more time so I don't neglect if they want to hop online and introduce themselves to you. I don't see them, so I'll introduce them to you. So Callie is joining the group that includes Philip and Diane, and they work in the job that we call Medicare Complaints Coordinator. So they handle relatively more complex cases and instances of potential fraud. And Millie works with us in the SHIBA hotline, which is the group that we've stood up to provide that first response to customers who call 1-800-562-6900 or live chat. So she's at that kind of interface between the organization and people that are calling us or text. Live chat web-based forms. So very, very excited to have both of them. And also, I sent you a note just ahead of the holiday that we created a new role and promoted Amy Fagoni into the role of operations manager. She previously was our operations supervisor. Before that, she was our was a regional training consultant and came to us out of being a volunteer coordinator. And I think I saw Gretchen with the outfit in Southwest Washington. Amy's away today, caretaking with her mom, but she's very excited about the promotion, and we're very excited for her as well. So here's my slightly odd looking pyramid diagram that's meant to represent that growing our staff team kind of at the bottom of the pyramid. The purple space is about making sure that we're aligned and providing the right kind and the right level of support to you as our sponsors. I know Annette is here, Stephanie, Kelsey, some other Andy, some folks who work in that role of volunteer coordinator, Tamara Smith, Marky Lockhart from O3A, folks that have this super important role of doing what I affectionately call care and feeding of the volunteers. So the social emotional support that is so important for recruitment and retention and recognition of volunteers, as well as handling referrals, being our ambassador out in the community representing the program. For us, that relationship is really central to the work that we're doing. The sponsors are our partners in technical skills training for the volunteers as well. And then, of course, the volunteer advisors, that's you, Tim, my friend Tim out in Kitsap County. And, my vision really is that this is a volunteer-run, volunteer-directed program, and that for me, these meetings are a bit as if we're standing up like an advisory council, and we as the professional staff are showing up and saying, okay, you all are co-creators of this program, and so let's make plans together and do that work. Maybe a little bit like a co-op grocery, right? We have two of those here in Olympia. I'm just a very strong believer in the reasons why volunteerism needs to be the heart and soul of this program. So what we're really trying to do here with the administrative work that my team does and the sponsors do is really to lift up the work that you're doing. I'm going to, as I said, share some data with you. The network is growing, which is a good success, and it needs to continue to grow because the needs of our beneficiaries are growing more complex and more urgent. And of course, just demography is that more and more people are Medicare eligible and staying enrolled in Medicare longer just because of longevity. So we're looking round numbers like 1.5 million Medicare beneficiaries, 220 volunteers created records in the STARS database, 17 sponsor organizations. So we just have a lot of, our little purple team has a lot of work to do to continue to kind of be adaptable and create a sustainable approach for the future. So with that, I think 2025 was a very good year for us. As with the past few years, it's just a lot about growing the capacity in our team, but we did increase the number of volunteers on our network. We did add more sponsors and community partners to our network. And of course, we grew our staff team. And I just take a moment to talk about the change in our staff team for a second. When I get to the part about future forecasting and I talk about the state budget outlook, it's going to be a tough budget year for Washington State. And I know that you all are politically aware and read the news and keep in contact with your local elected officials. So that's not news to you, but it is going to be a tough budget year. And so it's a little bit counterintuitive that our team is growing at a time when state government is shrinking. And what's behind that is that the funding for our organization is different than the way that most of state government is funded. So in Washington State, we elect our insurance commissioner. So our commissioner, Patty Kuderer, is one of 9 statewide elected officials. So she's not related to the governor's office or the governor's cabinet. So we have our own operating budget. So when the legislature comes back next week and we talk about budget exercises, the work of the legislature is to pass a capital budget and a transportation budget and an operating budget. And so we are one of those agencies that is, going to be looking for an appropriation for our operating budget. But that appropriation comes out of funds that we collected and essentially passed forward to the state general fund. Our state constitution requires that the industry bear the cost of its own regulation. So essentially, we have a premium tax that insurance companies pay that we collect, and then we ask for an appropriation of part of that funding back for our operations. And this account is called the Insurance Regulatory Fund. So because we have such strong support from the legislature and from the commissioner, we've been able to increase the appropriation that the agency gets from the insurance regulatory account for the SHIBA program. So on the last cycle, we got authority for 6 positions and about $3 million, most of which went out to our sponsor organizations. On this cycle, we have technically called decision package. So we have another request for an additional 6 staff, which I'm confident will be funded, but will continue to make the case to elected officials why. And then on the next cycle, starting the case for an additional 6 people in the SHIBA team. So we're going to continue to grow kind of the smallest part of the pyramid and see if we can then leverage those resources to continue to grow our sponsor network, our partner organizations, to continue to invest in those organizations so that we can, consequently grow the network of volunteer advisors so that we can reach more of the people who most in need of our help. So 2025, a lot about building capacity. 2026, still going to be a big focus on building capacity because we just have to kind of scale up, right? Medicare open enrollment specifically, my sort of shorthand for this is I'll often say publicly we do about half of the work of the program happens during the Medicare open enrollment period. The early data for this year is it's actually 43%. We had 221 individual people create at least one record in the STARS database. So that includes staff people of organizations like Tamra, who works for O3A, volunteers like Don Corbett, who works for O3A, and then in-kind partners who collaborate with us in the community and also create records in the STARS database. That accounts for more than 8,900 hours and almost 12,000 beneficiary contact records and beneficiary additional sessions. So across 2025, approaching 30,000 beneficiary contact records. So I think in that regard, my hat is off to you. That is a very, very successful open enrollment period, a very successful year. And I'll say for me that I feel like even if an individual volunteer recorded one record, it matters as much as a person who made 10 or 100 records, because the consultation that you had with that person for them was a life-changing event. And so I never want to discount the significance or the consequence of the work that you do with individual people because it just matters so much. Another highlight for us, of course, of the Medicare open enrollment period is we had this Medicare open enrollment jumpstart toolkit, and we distributed that primarily through libraries and senior centers, but lots of other outlets. Our sponsor organizations were very creative in finding ways to get this out in the community. We obviously had a large multimedia approach to support that effort, including paid media, radio, streaming, social media. I think it was a very good success. You're going to give us some feedback about the toolkit and the open enrollment period and 2025 in general, but let me just take a second to acknowledge especially Kendra and Rosie and Linda, who helped make that project happen, as well as tons of support from other people in our team at the OIC and with the State Department of Printing obviously our vendors. But I think the Medicare open enrollment period really was a very good success. And I think we have, and especially you have, a lot to be proud of. So let me just stop there and check in about feedback, your insights, your experiences that you want to share about the toolkit or the open enrollment period or 2025, the year in review.
Jim,
Hello, Prakash. Good morning.
Yes, good morning. I had a question on your previous slide. You had statements about community partners and sponsors. So who are those people?
Yeah, so for you and Aruna who live out in Spokane, like an easy example for me would be the Chaz Clinic would be for us like an in-kind partner.
Oh, okay.
So folks there have access to our STARS database and they do some counseling and referrals for us, and we provide some training support for them.
Oh, all right. Yeah. And what about the partner agency like Altio?
Yep, exactly.
Oh, okay. That's all right. Well, that's good. I
Yeah.
wasn't aware of Chaz being as a community.
And I know that you helped us out this year again at like the PEB benefits fairs.
Yes. Well,
Yep.
yeah, we tried.
We're gonna try again next year. We're not giving up on that.
Yeah, no, that's good.
Yeah. Good morning, Aruna.
Good morning.
How about other experiences or insights you want to share or feedback you have for us?
I have a question.
Hey, Charlie. Good morning.
Hi, I keep getting questions from people who have their provider can't make a deal with their insurance company. And I had a case where Aetna dropped multi-care.
Mm-hmm.
Aetna sent a letter saying these are the other insurance companies that we're working with because you can't work with Regions, I think it was. But the client was confused because it said Aetna HMO, but
Mm-hmm.
Aetna has a bunch of HMO plans. And this client's
Yep.
trying to figure out when they say Aetna HMO, is it any HMO that Aetna has, or do they have to identify which specific one it is? And they're very frustrated because they can't find out through Aetna. They can't find out through OIC. They keep getting kicked back to SHIBA. My recommendation to her was call your doctor and find out specifically who they work with. I don't know any other approach is so that's just my concern because I keep getting that kind of question.
Thank you for that. You sent me a note yesterday about that, and the
Yeah.
answer is yes. That's the right approach. They should check in with their doctor or their hospital or their clinic. In general, the answer is going to be any Aetna HMO, any
Oh, great.
HMO.
Okay.
And I can talk about this some more. So let me just do that right now. So among the challenges that you all had that we had this year was this phenomenon, and it's not just multi-care, but it's a lot about multi-care. And I was actually thinking about this last night, Charlie. We have a new dog at our house, Fiona the dog. So Fiona the dog and I went out for a walk last night around midnight, and she's she keeps her own counsel. So mostly, it's a silent walk, which is fine. It's a little meditation for me. And I was saying, we're going to have this conversation about multi-care tomorrow. And what should I say? And what should I not say about multi-care? And this is the conclusion that I came to. What you witness with multi-care is that, and I'm appreciating that this is being recorded, so I'm trying to be a little bit judicious here. But what you have with multi-care is this kind of rebalancing between providers and insurance companies around each of them trying to maintain some leverage one with the other, right? Because if the insurance company has a lot more power than the providers do, then the providers are not going to get the rate or the other terms that feel right to them. And then they're going to withdraw from participation, right? They're going to say, I don't want to be part of your network. Conversely, if the providers have relatively more leverage than the insurance companies, then the insurance companies are not going to stand up a network because they can't convince enough providers to come along. right? And so we're just in this long-term period of kind of the market coming to some kind of equilibrium, coming to some kind of maturity. And so what you witness with multi-care is where they've gotten sort of big enough that they can start to have a different kind of relationship with the insurance companies. And so how that manifests in the short term is that they're saying, we feel like multi-care, we feel like it's a better arrangement for us with you, fill in the blank insurance company. But let me just say United Healthcare, right? Because they're like the 800-pound gorilla. We're going to have a better relationship with you if we grow bigger and consolidate our operations, right? Hospitals, providers, ancillary providers. And we're also going to have a better, for us, relationship if we switch from PPO plan type to HMO plan type. So what multi-care is going to say publicly, and a very good relationship with multi-care, right? So I'm not throwing shade at those guys, but they're going to say, we feel like in terms of the quality of care, it's a better model for us in an HMO, right? In other words, if I'm the administrator for multi-care, I want to be able to manage your care better, Charlie. And I feel like I can do that better in an HMO model than I can in a PPO model, because in an HMO model, I'm functioning, my doctors are functioning something like a gatekeeper. I can say, hey, Charlie, let's talk about the care you need and who's the most appropriate person. And we can kind of consolidate things like medical records and billing. And I have a better kind of line of sight into taking care of you, right? Compared to in a PPO plan type where you're going to self-refer yourself, inside this directory wherever you like, and then I'm going to be kind of like watching you pinball around, right? Now, this is not to say that there's not also a financial incentive for multi-care, right? I mean, it would be naive to say that it's not also driving a better bottom line result for them. Both are true, but I want to be really clear that it's not just about the money, but the money is not inconsequential, right? And it is about that leverage that they're exercising in the market. Now, having said that, I think it's a reasonable kind of next guess to say where multi-care wants to go next is have their own insurance company. Why contract with United Healthcare when you could be the insurance company, right? And then you can direct that. And you see it exactly on the opposite side, right? Where United Healthcare has said, why be the insurance company when we can be the provider? Why don't we just buy Optum and run the Everett Clinic and run the Poly Clinic, right? So it's as if you have the providers on this side and the insurance companies on this side, and they're both arriving at the same conclusion, which is when we need each other, we want to have influence. And wouldn't it be nice if we needed each other less? I mean, can I say that? That sounds a little bit casual for Thursday morning, but that's essentially what's going on here. So in the short term, this advent of HMO PPO is part of this long-term kind of migration towards resetting this relationship. Is that helpful?
Yeah.
I mean, I get
Again,
that. I get that you walk away from this conversation feeling like, so the beneficiaries are kind of just a pawn in this big game, and I'm like, well, that's not really the conclusion that I want you to draw. But the short answer is yes. They're going to take any of the HMO products. They don't want the PPO products, and check in with your doctor's office. Now, having said that, there is still a lot of friction and confusion. Doctors' offices, even the businesses' offices are wrong and confused, and they say the wrong thing. And I sent you guys this long note that said, as the beneficiary, when you call, you have to be explicit and say, I belong to an employer group plan, right? So that's different. Or I have Medicaid. I'm enrolled in a dual special needs plan. That's different. So, right. So if you're, this comes up a lot, right, Prakash, with our PEB members. So the United Healthcare PPO for PEB beneficiaries, they still want that. because it's a group plan, or the plans that are offered for our dual eligible clients, they still want that. So it's this commercial market space, right, is different. So again, it comes back to the idea that it's very important that we know which market is our client in, not just which system, not just original Medicare or Medicare Advantage, but is it employer group market compared to commercial market compared to Medicaid? Because this thing that we're talking about, this HMO PPO plan type, that's a commercial market problem. They still want all the employer group plans. They still want all the Medicaid plans. It's these commercial plans that we're negotiating around. That's a lot. How are we doing?
Well, from my, just selfishly, if a client says, I don't know what it means if it says HMO, and the answer is talk to your doctor, try to
Yep.
get it specific there, because they run into phone trees with the insurance company and so on. Fine. I'm not going to dare to even attempt to explain what you just explained to them. And I don't think they need to know it necessarily.
They
Um,
don't. They don't. And I was in Yakima a handful of times this year, working with Stephanie, who's here this morning, and Kelsey. And we had a big community meeting, 100 people. Multicare was in the room for this conversation, which was great, because a lot of people got a letter saying, pick multicare or pick a different plan. And they didn't understand the letter and they didn't know what to do, right? And the multicare website was horrible. And they kind of blanched when I said that publicly, but it's real. It was horrible. It's getting better, but it still could be better. But yeah, from a client perspective, connect with the business office at the hospital or the provider, and be as explicit as possible. Get out your insurance card and read it to them.
Thank you, Tim. That's helpful.
Yeah. And again, I think for the 5 years that we've been working together, and for whatever time, 5 years later, it is a long-term problem, right? We're the work that you have, and I'm going, back to an hour ago when we started. It's just you have a very complex assignment, and it's not going to get simpler. But I know you can do it, and I know we can help support you to do it. But I just feel like we have to have like a PG rated conversation, right? Like you're working inside a very complex system, and so we just have to have some, as my grandfather used to say, intestinal fortitude, right? We're going to have to level up here. So these conversations are important because, yeah, what I'm telling you is more like for your orientation. I'm not scripting you for your client call. If I was scripting you for your client call, it would be more like, okay, haul out your Medicare open enrollment toolkit. It still works, even though it's not Medicare open enrollment, because we can cite you in the right place. Let's talk about the kind of insurance you have. I understand that you don't know what kind of insurance you have, so dump out your purse, dump out your wallet. Let's get out that Denny's menu and say, okay, you said that you have a Medicare supplement plan, but you actually have a Medicare supplement plan from the place you used to work, right? You are a retired Department of Energy person. You live in Pasco. You were a civilian contractor of the Department of Energy. You have an employer group plan. So although you think you have a Medicare supplement plan, you have an employer group plan, right? So that's different, right? You have VA, you have TRICARE for life, you're a retired school teacher. That means you have PEB. That's not this. Your United Healthcare is not the one that they don't want anymore, right? So if I was scripting you, I would say, have that interview conversation, make sure that you know where they're at, make sure they know where they're at, and just say, hey, look, Tim, your rights and options start from the kind of insurance you have now, based on what you've shared with me, the letter you brought from the community services office, or the insurance cards you have, or we called 1-800-Medicare together. Now I know you have QMB. You can do this. Or now I know, you're a commercial market plan. You can do this. So if I was scripting you, I would say, come back to your source material. What kind of insurance do you have? Which market are you in? Which system are you in? And then talk about, hey, let's talk about recent correspondence. Did you happen to get a letter or a note? You're supposed to get an annual notice of change. If you didn't get one, let me help you get one, right? So this conversation, I guess, maybe my somewhat editorializing is just to give you some context and to help you appreciate why there's so much prevailing anxiety out there. I don't know. Have I had too much coffee? Did I get up too early in the morning? It's hard to say. Hi, Prakash. What do you have for us?
Yes.
Yeah, this is Aruna. I had a question about you mentioned about Department of Energy. So if there are federal employees, what are the issues, and do we have any knowledge base how to
Oh,
help people in that arena? Because I had somebody ask about that.
I know you do. I know you do. Well, remember a couple of years ago, all of the drama was about postal workers, right? And the changes in the postal service. Um, and so, yeah, federal workers, I mean, we get a few. I guess I'll take a note that we can make sure, our best contact is, I guess the analogy, Aruna, would be like where you have the healthcare authority for your PEB benefits, they have the Office of Personnel Management for their federal employee benefits. So, unless they're like a TRICARE for Life person, but then we would refer them back to Office of Personnel Management because they have this whole raft of plans and all of these rules. And I'm sure you're aware, but the complexity with them is there are still some federal workers that were not enrolled in Social Security, not required to get Medicare Part B, and so that shows up from time to time. But um, I would say do your best, and then reach out to Noreen or reach out to us. But Office of Personnel Management.
Okay.
I'm never expecting all of you to solve all of the problems. That's, again, like growing our team a little bit is about creating that backstop for you. So you go as far as you feel comfortable, and then we can come alongside of you, or we can take the case. But you should never feel like you're without resources. We are 100% here to support you.
Thank you.
Thank you.
Mm-hmm. How about some more questions or feedback about your experiences, insights? Toolkit, open enrollment, 2025. Can you remember 2025? It wasn't that long ago. 2025, can we just say difficult year, challenging year in so many ways? Very challenging year. I celebrated New Year's Eve with some friends of mine in Port Townsend, and they were all like, man, I'm glad that's over. I'm like, oh, okay. I'm not sure 2026. You might want to just take a little pause break here because 2026, challenging year. What do you have for us, Prakash? Hmm? Arun, are you thinking about it? Thinking about how to phrase it? Are you about to say something unfortunate that would embarrass your children?
No. I forgot to unmute. I was thinking about if working with people who are in their 60s and 70s is different from working with people who are in their 80s and 90s.
I know we're so
And I
immature.
have seen that kind of dynamics play out. And I wonder if we need more education around those issues, how effectively work with populations in different generations.
100%. I think you're 100% right, Aruna. We're just I don't mean to sound defensive. We're just paddling as fast as we can here to catch up. But yes, I would say that phenomenon, when I do public presentations, I talk a lot about the fact that, a person who's starting Medicare this year at age 65, they're going to be in Medicare for 20, 25, 30, 35 years, right? And their needs and their experiences are going to change across that time, for all kind. And being careful not to be ageist, but it's true that you change, right, over time. And then the number of people that are institutionalized, right? And we don't have a great solution for working with the nursing homes and the assisted living, because that's different, right? So I think you're 100% right. My team, we need to do more support for you as people, um, old people grow older, become infirm, move out of their own homes, depend more on other people as caretakers, or we move into power of attorney or guardianship. We have a lot of catching up to do to help you with that. 100%. Yep, that's definitely on our radar. Hey, Scott, good morning. Nice to see you.
Thank you.
Hi, Kim. So if I was going to give you some feedback on the toolkit, one would be there's a lot of paper, and I
My
found
fault.
with a I found with a couple of groups that I worked with that it became very confusing for them.
Yeah, yeah.
Okay. Um, and the other piece is, well, there was I mean, actually, it was helpful if people were paying attention to it, could take the patients to walk through each of the pages and say, oh, no, that's not me, or that's not me. Then when you get to the point where you're instructed to use the plan finder, I felt like it really needed more information there
Hmm.
about how to use the plan finder.
Yep.
Because if you get all to that point and you can't use the plan finder, well, you haven't accomplished that much. You've
Hmm.
identified what kind of insurance you have or where it comes from.
Hmm.
So that was just my observation when using it with groups.
Okay, that's very helpful. Yeah, no, that's very helpful. Um, yeah, it's long because I wrote it. It's long. Um, um, you know what? A lesson learned. My intention was that like if you figured out that you were like 4.2, you would just recycle the rest of it. But no one will let go of any of the paper. They won't let go of any of it. So okay, that's a lesson learned. Um, and the plan finder, that I mean, honestly, that was a big frustration for all of us here this year because I had heard that there was this possibility of multi-factor authentication coming online. And I was very worried about that. And I didn't know what to do about representing that in the packet. And we ended up really deferring. We ultimately created some online video about using the Plan Finder tool, but it was probably 2 weeks after the start of open enrollment because I was waiting to see where they were going to kind of end up with. Ultimately, as you know, we ended up with you have to have an email to create a new account, and that was super off-putting for people. Um, so yeah, that's a good note about the Plan Finder tool, and we do intend to recreate the toolkit and use it again next year. So I'm sincere about asking for feedback. I'll also say it was really by me designed to be more for in-person counseling compared to public presentations. It was kind of meant to do both things, but I appreciate that it didn't work as well for public presentations. In the first two town hall meetings, I got good edit about um, we have a lot of people who show up for those, whether they're virtually or in person, and they're not actually open enrollment. They're getting ready to start in Medicare, and we need to think about blending the materials, maybe even blending the packet. So that's a good edit, Scott. Thank you.
Sure.
Yeah. Hey, Julie, nice to see you.
Hey, good morning. So I've been kind of mulling over because this open enrollment, I had a larger percentage of who I will call, I'll say, I'm guessing wealthier clients.
Mm-hmm.
Because the folks, thinking about prescription drug plans now, the folks who are on a tight budget seem to always be really good about coming in, help me find a way to get my meds for less. And that's really a strong service. But usually at open enrollment, I'll have one or two of seniors who are way overpaying for their prescription plan and they're like oblivious to it. It doesn't hit their budget, so they aren't paying attention. And I
Mm-hmm.
had more of that this year. And the worst one was an $83 plan, and she took one generic. I mean, there was no reason for her to have that. But because it didn't matter to her budget, it wasn't on her radar. And I'm
Mm-hmm.
thinking, is there a way we can help people come and check, even if they aren't looking to save money particularly?
Mm-hmm.
Because I feel that we're probably missing some people, and maybe with some of the more expensive Advantage plans also, where they're not probably getting the value of that monthly premium. And it's just a matter of getting them in. We can explore, But I think
Interesting.
if they're not feeling it from a cost standpoint, they just maybe
Mm-hmm.
don't come in for 5 years, and then they're way overpaying because costs have crept up.
That is a great observation. I think I don't have an answer for you in the moment, but that is a great
But
observation.
just yeah, because I just feel we're missing that. We're missing those people. And even though
Hmm.
maybe it doesn't matter to their budget, I feel like, hey, coupon clipper, how can we save you money? That's just me, you
Absolutely.
know.
No, absolutely.
Mhm.
I'm going to think about that. I don't have an answer in the moment, but that's an interesting observation.
Uh, and can I add 2 more cents to that?
Please.
I had a client, a couple, in 7 years that they had been in Medicare had never reviewed their coverage. And I think for the same thing, it was like, well, we can afford that. So they didn't know that they could save money by reviewing it or taking the time or how to review it, which so I think there is a whole population there that could benefit from being aware of there is a because it would seem complicated, they just didn't do it and they could afford it. But in the
Yep.
end, if they had chosen a different plan the previous year, this couple would have saved $2,100.
Wow.
So it was huge.
Hmm.
Yep. So I guess I don't mean to put you on the spot, but Scott or Julie, do you have a sense of like if we were going to like produce some, piece of mail or get on the radio, like what would be the hook? Like what would motivate them? Because I'm going to agree with you, Scott. Like I think a big reason people kind of look the other way is it just feels icky, right? This is complicated. Um, why engage with something unpleasant? But and I don't mean to put you on the spot, but maybe
Well,
um,
you know,
what's the hook? How do we get their attention?
the couple said to me, I did call the company and I asked if this was the best plan for
Uh,
us.
yeah,
And they said, yes, it was. So that satisfied them.
right,
Well, that company only offered 2 plans, and this was the cheaper of the 2 plans, but obviously it wasn't the best plan because that company was not going to tell them that they could have gotten far less, with like a WellCare value script plan.
right,
Yeah,
right.
So it's taking that
I'd have
extra
to
step.
think.
Don't just call the company, but they need to go to a neutral party like SHIBA to
Yep,
get some real assessment.
Yeah.
I got it.
I
What do you have for us,
And
Julie?
anyway, I haven't thought of the like this the solution, but I will
Great.
mull that over for some suggestions.
Okay. Well, you have had some I don't mean to like embarrass you, but you have been a great force on Whidbey Island in terms of improving kind of the promotions and publicity for the SHIBA program. So it's a
Mm.
sincere request. You're very good at this.
Oh, okay. Well, thank you.
Yeah. You guys on Whidbey Island, you did great. I don't have the data like right here in front of me, but there's this funny expression that the federal government agency has about like the numerator is how many people did you help, and the denominator is how many Medicare beneficiaries are there in that space. And I'm like doing this off the top of my head, Julie, but I think you guys are like approaching 10%, whereas like statewide I'm like 1%. So you guys are doing great in terms of creating awareness of the SHIBA program, and then that goes for you as well. You're kind of my anchor in a positive way, not a negative way. You're like my anchor out there in Whidbey. All right, I got Prakash and Tina and Charlie, please.
Julie and Scott's observation, we too have noticed, sometimes the rationale is I don't like the pharmacy that I'll have to go, and this is the easier pharmacy because the pharmacist works with me. But I think Julie and Scott's observation is well taken. People who have money, they just say, I can afford it and I'm going to pay for it. I don't want to change because it is going to save me so much money.
Mm-hmm. Mm-hmm.
This is not only in that part of the state, but also everywhere.
Yep. Yep.
I,
And I do think the pharmacies are, we can be a stronger partner with pharmacies, especially the independent stores. Yep. Hey, Tina.
Uh, Hi. About Julie's point or the idea of how to reach people. I'm wondering about what data we could get at. I remember, I think last year, maybe 2024, I heard a statistic from the pharmacy school in one of the pharmacy schools in Central California where the pharmacy students do a
Mm-hmm.
SHIBA-like service about
Mm-hmm.
drug plans. and their data was that 75% of people who check their plan save money. But I'm wondering about finding some sort of statistic like that.
Yep.
Because I think even people with a lot of money can like the idea of saving money.
Right.
If we could get them a strong enough hook or something compelling enough data that could make it help them get over that hurdle of both making the change and seeking help. But then yeah. Anyway, that would be one idea. But I had also a question in terms of our service and impact on the program about what's happening about broker compensation. Because I
Mm,
know locally we don't have very many brokers that we mm, would readily send people to,
mhm,
the one strong one that is reputable was just overwhelmed and reduced her
mm,
service,
mhm,
which then means,
mhm.
but which is fine, then we need to serve those, but then we need more capacity, that really speaks to the SHIBA capacity. But I'm wondering, I know you sent out that letter that Patty
Mm,
Cooter had sent. Do we have any concrete data about what's happening with broker compensation? And
mhm.
I've heard kind of different stories about none and some and reduce, but I don't know what those real life numbers are or the impact on even if these brokers can continue to serve Medicare people.
Yeah. Okay. Wow. That's great. Great question. Yeah. So I think um, for people that might not be aware, for context, what happened here was that some of the, and I'm going to say United Healthcare just as an example, right? Um, in a way that felt very abrupt to agents and brokers, changed the commission structure. They reduced commissions, they eliminated commissions, they changed the tools that the agents and brokers have access to. It was very, very upsetting. Uh, Shortly before this happened, I actually had done a presentation. The OAC sponsors a group called the Producer Advisory Committee. So producers for us is our term of art for agents and brokers. We call them producers. And I had done a presentation for them because there's always like a small amount of tension between the SHIBA program and the producer community, right? Because some of them feel as if um, like we're taking business away from them. And some of them feel as if like we're not as qualified to do this work as they are. So okay, that's fair, right? So I had done that kind of conversation with them, and then the changes started happening. So I was kind of on point for the agency to respond to those, and and kind of like the lightning rod, so to speak, for this was that the Idaho Department of Insurance issued a bulletin telling the companies like knock it off, right, a cease and desist order, and then subsequently the company sued the Department of Insurance, and the district court heard the case and said the insurance department is wrong, the company is right. So it's all being litigated. But what it comes down to in Washington state is that we had a consultation with our assistant attorney general, and we were really clear that we didn't, by statutory authority, we could not kind of step into this space. Um, Most recently, then the Medicare agency CMS issued a letter to all the departments of insurance, kind of reminding us that stay out. This is federal business, not the business of the states. Preemption applies. So there's just a lot of tension about this. Okay. So the real life impacts is much more on the independent agencies, the smaller agencies, the folks that a significant part of their revenue comes from helping people with Medicare Advantage plans, especially. Um, we have had a really dramatic reduction in the number of standalone Part D plans. So you'll know that this year there's only 10 in Washington state, and that's 10 plans. That's not 10 companies.
Wow.
And that kind of is gonna my prediction gonna continue. Because that market, it's just not as viable as the Part D benefit embedded in the Medicare Advantage plan benefit, right? That's just about the way that CMS pays the insurance companies. And so, okay, so I think we're going to continue to see that. So we actually had this challenge. My friend Catherine Stevenson, who's on the phone, had a little bit of a dust up with a local agent about this, because that agent felt like she wanted to get compensated for helping people with Medicare Part D enrollment, and that's not allowed, right? And so it was kind of like she wanted to retain the client, and Catherine, appropriately said, "Look, the client goes where the client wants, and if they want free help, I'm going to help them, right?" And so there is this tension, but Catherine did perfect. Um, it's hard to get a sense of kind of globally the impact of that, but again, in that kind of crystal ball way, Washington was kind of the camel's nose under the tent, if you will. I think you'll see this happen in other states over time, that the companies are kind of solving around, does it really help the company to pay commissions to agents and brokers? Because when you call 1-800-Humana, you immediately get a licensed agent on the phone, right? And so I think they're trying to figure out where they want to be at. And back to our multi-care conversation, that the big providers are also doing that same thing. So if you call multi-care, they say, we like working with this brokerage, they will help you. Or if you call, fill in the blank, University of Washington, we like this brokerage, right? So again, I think the producer community is trying to figure out how to align themselves relative to the providers and the insurers, but the commissions in general are shrinking. CMS is regulating that more tightly. So I think it's going to be long term, like, less attractive. We will see fewer people seek licenses to sell insurance for Medicare Advantage plans over time, which I don't think is a bad outcome, because there was, a lot of kind of predatory stuff happening, right? Where someone would just want to become licensed to sell insurance ahead of open enrollment, do it, and then quit. So I think there's a similar dynamic about that kind of resettling. I heard from a dozen or 24 agents. We're going to continue the conversation, but I think that it was a lot about the timing. Like, it just happened very abruptly. The communication from the agent or broker perspective was very poor. But I think it was like it was a seismic event, right? Next year will not be the same. We're going to see a bunch of producers withdraw or reconsider. We had way more referrals to us from agents and brokers than we've ever had in the past, which is not a bad outcome. But we weren't ready for that necessarily, right? So I have some work to do in the year ahead to continue to work with that community at large. I had some conversations with them. I'm going to continue to kind of promote that conversation with them. And I'd love to hear from you all about your experiences, because I think the new year is a chance to reset that relationship a little bit. And I'll start with kind of the association and work my way down to individual agents and brokers and local communities. And it matters more in small communities than bigger ones.
I also had the experience, sort of, when you talk about the provider and the broker,
Yep.
with calling Optum customer service, I think, for trying to see if they could get the information about what plans were accepted by a particular doctor. Because I
Uh-huh.
think even some of the Optum stuff on their website says, contact your provider's office, right?
Right.
So I jumped to that hoop, and the customer service person said, "Well, we're the agents in our office, in our clinics, they can tell you." But
Yep.
it's like they had no information. So to Charlie's point, about helping people figure out where their plan will be accepted, is like, so then did try to call that person, and they were, or figure out about, I stopped in the clinic. Oh, that's what I did. So then I stopped in the clinic, and the person there was nobody there. They were only there from 8 to 12. So then it was, did I want to leave but it was like the clinic itself wasn't going to address the plan choices, or the plans that they accepted. Anyway, it is very complicated now and I assume these are larger agencies with a representative there, but yeah, I
Yeah.
don't know.
I mean, just like put a quarter on the bar and bet while we're drinking a beer and having pretzels. I'd say don't be surprised if you see, like, when you go to Costco and they sell eyeglasses and then next door they have an independent doctor of optometry. So don't be surprised if you go to the doctor and there's an independent agent's office next door. Totally me making up a story, Tina.
And go to the agent to find out what insurance we accept.
Right.
We can't tell you.
Right. Yeah.
Well, my comment would be that in the case of the client I had, she received a letter from Multicare in early December
Mm-hmm.
saying, "Oh, by the way, Regents isn't being covered anymore,"
Yep.
right? And so
Yep.
she had like and the 1st of January now. So now, right, she's basically right now in a situation where she doesn't have coverage for her doctors because they're in the Multicare network and now her Regents plan. And she gets one choice to change that plan, the open enrollment. And she's
Mm-hmm.
afraid if I make the wrong choice, I'm kind of doomed, right?
Right. Uh,
It's just like, "Wah."
It's a very high stakes decision. Yeah, I mean, she's not wrong. She gets one choice. Charlie, Rosie is here, and she's the RTC that works for Pierce County, where you work with Tammy at Santa Outreach. And I would say check in with Rosie to ask if there's any other options.
Okay.
Potentially, the client has a trial right period or some special enrollment period, but likely it is going to come down to kind of making that high stakes decision.
Well, I think your comment that probably any HMO is probably going to be okay. And then if she
Yeah,
goes back, I told her go back to your original doctor and find out from him. And I said to some, put on your wart shield and go for it in the doctor's office, and I
yeah.
hope she should be all right.
Sad to think you have to gird your loins to go to the doctor's office, but we may be living in those times. I'll just say one other thing because Rashmi, thank you. You've been very patient. When I was in Yakima, and I sincerely believe this, you're not going to get worse care if you flip from a PPO to an HMO. It's not going to be materially worse. And I know that that's a very big concern for people. I use the expression in Yakima, like people like me, we want to be a free range chicken. We just want to do whatever we want, whenever we want. And so the idea of an HMO, we just kind of reject it out of hand. I would say you can, if I'm coaching you all in your counseling, you can reassure people. It's not as restrictive. It's not as daunting. It should not be as fearful. They're going to get the care they need. They're going to get the referral, especially with multi-care. They're not going to get shut down, locked out. It's not that. Some people are holding on to an image of an HMO from 1970 or when they enrolled with Group Health Co-op, and maybe we have to let go of that a little bit, especially with multi-care. Rashmi, you've been very patient, and this is the second time I've seen you this week. Welcome back.
Thank you. Happy New Year. So my question is around Medigap plans. So there are 10 plans, but the premiums are kind of range from 200 some to 300 some. And when I explain to clients that the benefits are same across the board, doesn't matter which plan you pick, I think they are a little bit apprehensive to pick the lower premium plan. And so how can I convince them? And they are looking for rating. There's no rating for, for those plans. And I try to explain them the customer service should be the same from those insurance companies. That's my first question. And the second question is the HCA Medigap plan. Seem like it's a little bit challenging for the clients because they have to request for application and fill out the application. Is there an easier way to apply for the plan that's offered in Washington State through HCA? How can I help with that?
Those are both great questions. Okay, give me a second. I think the first thing I'm sure that in the people on the call and then the people that you work with, every volunteer kind of finds their own way of explaining that thing that is a standard plan to people. So I will often use the metaphor of My wife likes to have a poached egg for breakfast every single day, 365 days a year. My house can never be out of eggs, ever, under any circumstances. It can cost $1,000 a dozen. I got to go get a dozen eggs. So I use this analogy like, there's a big truck that delivers eggs, and there's a local egg producer, Wilcox Dairy, and the same person drives the same truck with the same eggs all over Olympia. So the fact that they cost this price at Costco or this price at the Frog Pound Grocery or this price at Safeway is not about the product. It's literally the same dozen eggs. The price is just, it's a commercial market decision that the company made, but the price is the price. The product is the product. So I'm sure everybody has their own way of explaining that to people. But I think at the end of the day, my expectation of you would be you just do your best to explain it. And if they spend more money, maybe they just do that in the beginning, and over time they get more comfortable. Jar of mayonnaise, right? Um, but it is the same product. About the ratings, that question comes up all the time. So two thoughts about that. One is that these are generally very big companies, and so a diligent person could like look them up like on AM Best or Moody's and see their bond rating, but they're all solvent. The insurance commissioner's office regulates those companies, and part of our review is about solvency. And so none of them are going out of business. And if if they did go out of business, then we have this thing called guaranteed issue. So another company will absolutely take all of those people with no underwriting. So your company is not going out of business, but if it did, you will absolutely go to the next one with no problems or concerns. And customer service, it's a little delicate to talk about because there's none. It's all automated. It all happens in the background, right? Medicare pays, and then they literally ship the data to your insurance, your second insurance, State Farm, and then State Farm pays. Human beings are not even involved. So the only customer service to speak of is getting started, right? So I mean, I understand the concern. People are very apprehensive, but it's pretty straightforward. So I guess maybe a suggestion would be if you help someone get started and they choose a $300 plan instead of a $200 plan, say, maybe check in with me in 6 months or a year, and let's see if you're more comfortable with switching to a lower cost plan or moving to a different plan. I guess, and I'm open to feedback from you all on the call, but I think that's what I would say is for you, be comfortable with them making a choice that you feel like they're spending too much money. Do your best to explain it. The concerns about solvency, customer service are not material. It's like saying it's not the same kind of product as 5-star rating for MA plans. They're very simple products. The HCA plan for Primera, that just annoys me no end. I don't have a good solution for that. I'm banging on Primera all the time. It's a challenge. I'm going to try again this year, but it's a challenge. So I guess I'll create some materials for you guys. I've been working on this for a while, but I guess the first thing to understand is that it's a group plan. So it's not an individual plan. So on that giant list that we have for you, they're all individual plans, excepting the United Healthcare AARP plan is a group plan. So you need to be an AARP member to get that. And the HCA plan through Primera is a group plan. So that group literally is people like Prakash that are retired from the state of Washington or other political subdivisions. So as a policy decision, we've created access for the public to join that group, right? So it's a group plan, but individual people are allowed to join. So then we're regulating who can join. So again, I swear, tons of respect for my friends at Primera, but they make me rabid. So we have in the Washington Administrative Code, we describe the eligibility for that plan because the state changed the rules to make that plan available to the public. So you can look at the WAC and say, this is who's eligible. And then when you look at their application form, they don't line up.
Yes.
right? So we're translating what they put on their application back to the WAC and saying, you really are eligible. They really do have to take you. And then my team is always problem solving. We're on the phone with Primera saying, your agent told them the wrong thing. Please fix it. But we're always right and they're always wrong. And it's always clear because there's a WAC. It's really written into the rules, right? So I don't know. It's a persistent problem. And so yes, that plan was designed. We took a policy decision because a long time ago, say 20 years ago when I used to work here, we had kind of a hardening of the market for Medicare supplement plans, which was about the way that we were regulating them. And so we created that kind of as a safety net for people. And it has been awkward ever since then. But it kind of waxes and wanes because periodically they're the lowest cost plan. So people scan that chart and they're just saying, oh, Rashmi, you told me they're all the same. Let me just pick the cheapest one. Oh, it's that one. Oh, I can't get it. It's wildly aggravating.
Yeah.
So
actually, I myself ordered the application from Primera, which was kind of jumping so many hoops.
Yes.
Because first the brokers didn't even know. They say, oh, you just call this. So I did get the application, which talks about PAB a lot. And,
right.
General audience is not PAB, maybe.
I know. And I swear, I can't tell you the number of times I've had meetings with those guys and we're making progress, but it's painful. It's not better. Honestly, it's not better. I'm frustrated that I'm not doing better for you, but I'm not giving up.
No,
Even
thank you.
people that
Thank you
don't
for
like
your
me say I
feedback.
don't give up.
Yeah, thanks for the feedback. Appreciate it.
You're welcome. Not giving up yet. We're going to try again. Okay. I guess I want to just, hey, Susan Ross says, I have a system for helping people. Susan Ross is one of our great volunteers with Scott up in Bellingham. So Susan, maybe you will dump your email in the chat for us so people can reach out to you for help with the application and recipes. No, just kidding. Help with the application. That's okay. Tina, whoops. I lost my screen share there. Try again. I'm not, as I said, I'm not wedded to my PowerPoint slide deck, but there is two things that I want to make sure we talk about while we're together. Prakash, I'm not ignoring you and Aruna.
That's okay. Yeah, go ahead.
So let me just, I have 15 minutes. Let me talk about this project that we're going to have in the year ahead. Some of you will be aware, many of you will not be aware, because many of you are retired already, and so you're not connected to this the same way that I am. So in Washington State, we have this thing called, now on the other hand, Marky is here, and Marky is very attached to this because she works at the Area Agency on Aging. And Marky, help me out if I miss something important, okay? So in Washington State, we have this thing called the WA Cares Fund. And essentially what it is that as a working person, I have a payroll deduction that gets invested so that when I'm older, if I need my technical expression for this is going to be long-term services and support. So I need institutional care or home-based care because I need help with like activities of daily living, right? So the WA Cares Fund is I'm gonna say it's a defined benefit program. So after my continuous payroll deductions, then I have like a bank account or a piggy bank that I can draw on that's about $36,000 to help pay for services that I need, long-term services and supports, either institutional or facility-based care or care in my own home, including paid caregivers, including family members who can qualify to be paid caregivers. So the WA Cares Fund, we've been litigating this for a number of years, but it's finally going to go live in the summer. And so we're doing a pilot project right now in Spokane County and Lewis, Mason, Thurston counties to kind of test this end-to-end process of enrolling providers and beneficiaries drawing down their benefit and paying the providers. So it's kind of very early days, but the most recent version of the bill that passed in the last session directs the OIC SHIBA program to produce a consumer's guide to supplemental long-term care insurance. So what that means is that we will continue to have what I'm calling traditional long-term care insurance policies, the kind that you all may be familiar with. You may even have one, but like only in Washington State, because we have this WACARES fund, we're also now going to create a market for what are called supplemental long-term care insurance policies. So these will be policies sold by private companies. So let's say like John Hancock is going to offer this policy in Washington State to people like me, and it's going to be like, hey, you have that WACARES benefit. You might want another insurance policy to kind of come alongside of that to provide extra insurance, make your $36,000 go farther by buying a policy that will supplement your WACARES fund benefit. So it's a little bit of a guessing game about when will companies come into the market, how many companies will come, what will the products look like, how actively, right to your question, Tina, how actively will the agents and brokers engage this? Who will be representing for the companies? So there's just a lot of uncertainty about what this like really literally looks like. But on my side, it's my responsibility to follow through with this legislative mandate and produce this consumer's guide to supplemental long-term care insurance. We're going to revise our current consumer's guide to long-term care insurance, which is more about these traditional insurance policies. We're going to hire a person into our team to help with education and outreach related to this insurance, this supplemental long-term care insurance. And I'm going to be reaching out to you through your regional training consultants and your volunteer coordinators and the folks who, like Marky, work at the area agencies on aging to say, are any of you interested in learning more about WACARES fund, traditional long-term care, supplemental long-term care insurance, and potentially kind of making that be part of your portfolio of counseling that you do. So I want to be really clear that it's not an obligation. It's not like overnight I'm saying, okay, Rashmi, now besides Medicare supplement plans, learn about supplemental long-term care insurance. That's not what I'm saying. I'm saying that if it's a thing you're interested in, we can kind of we can do like a primer about it and talk about it. And then you can say like, yeah, I might be interested in helping about that, but we'll just do it, baby steps, right? But I think I've been really clear with my leadership and the staff of the elected officials that I work with. I said, I can't just convert my whole SHIBA network overnight to be counselors about long-term care insurance. So we're going to have to think about kind of creating a specialized role for people that like doing this and have an aptitude for it and want to. So all of you are welcome, but it's not going to be compulsory. So I just want to, for today, like raise the awareness with you. And when we look ahead to the April version of the town hall program, hopefully by then I've got a staff person in place. I have a consumer's guide at least drafted, and we have a little bit more definition about what our support for you might look like if you were interested in learning more about this or kind of trying it out. So for today, it's more just like for awareness that this is coming. Okay, so I'll stop there. And anybody want to say anything? Marky, do you want to say anything? Did I do anything horrible there that you want to correct?
No, I
Nope.
think you did a really good job. And, I know we have a meeting later and you've already answered some of my questions far later, which is great. But yeah, the Washington Cares, it is just another tool in the toolbox. And my question was, what was OIC going to do to help educate folks? And there you go. I know we'll be with our team. We'll just be doing some general introductions, and I think it's just important for people to realize that it's coming. And July 1st, folks will be able to access their benefits for those who have paid in and qualify for the program. So I just encourage y'all to. There is a website for Washington Cares, so if you want to start educating yourself, check out that website and reach out to your AAAs as well, because we're the ones that will be helping navigate those benefits for folks for Washington Cares.
Mm-hmm. Yeah, it's I'll say it's a great. I'm a strong believer. I'm a strong proponent. And it's super complicated, and it's gonna create a lot of confusion and anxiety for people. It's a bit of a stretch for us because, in general, people who should buy long-term care insurance policies are not 60-year-old people like me. It's 40-year-old people. And that's not typically who we're counseling, right? Except for younger disabled people that are coming into Medicare or SSDI clients. So it's going to be a challenge a little bit, right? But I also feel like it's a great opportunity for us to foster that relationship with the area agencies on aging and the aging and disability resource centers and the advocates who work with aging programs and, again, institutions. So we're gonna, in short order here, stand up a work group, and we'll include the long-term care ombuds office, my friend Patricia. So I think it's a stretch, right, at a time that we're already stretched. I know, I'm acknowledging that. It's one of those things that I can't affect it. I'm told to do it, right? They wrote a bill. I did a bill analysis. I wrote a fiscal note, and now I am just it's here, right? So I'm being a good team player, but I'm acknowledging that coming to you guys and saying, "Hey, how about some more work?" You're kind of like, I hope you're joking, right? Because we just finished open enrollment, and I'm like, I know it's a lot, but thank you for your consideration, I guess, for today. What do you have for us, Kendra?
I just wanted to say, even while you're saying nobody has to do it, and we're being told to do it, you have an incredible amount of interest in chat. So Sandra said she's interested in learning about long-term care insurance. Yanin Diaz says CMAR Community Health Centers is interested in learning more about WACARES. Charlie Sheldon very interested in the long-term care idea. So you have a lot of people in this room who are already on board.
Appreciating that. And Sandra, let me acknowledge, I think I've seen you 3 times this week. So thank you for being here. I appreciate your support. And Yamin, thank you. Yeah, CMAR, very important partner for us. Back to Prakash, your question about who are these community partners, CMAR, great partner for us. Kim Younger, who do you have for us out there from the peninsula?
Hi. So this kind of brings back to memory when the Affordable Care Act was first implemented. I believe that there was a call out for SHIBA volunteers to, if they wanted to be, I think they were called navigators. I don't remember. There was an actual term for that. And I think there were some SHIBA volunteers that stepped in for that. There was some initial funding, but then that funding dried up. And so over time, it seems as though the role that the volunteers played has gone away. And partly probably because, as we know with Medicare, things are always changing. The rules are always changing. And so I guess, I'm interested, but I have some concerns about, the ongoing support that we as volunteers would receive to be competent in counseling, and whether or not you anticipate that this would be just a transitional role we play, which I think is important. I'm not discounting that. Or if it's a long-term arrangement. And so, I mean, I know you probably don't have an answer to that. I just want to throw that out as a concern.
Super fair concern. I have that same concern, Kim. The first time that we saw this bill that directed the OIC and the SHIBA program to do this, I wrote what I thought was a pretty thoughtful response, and I included 7 as the number of people that the SHIBA program should get. And I got told, like, politely, like, not in 1 million years. And so I think it's a sincere concern, right? If I have one person, which is what I have, that becomes kind of a governor in a way, right, on what our response can look like, both initially and like on a sustainable basis. So I do want to be very careful to not kind of blow hot and cold about this, right? And to your observation about the ACA plans, Obamacare, health benefits exchange, that was a policy decision that initially the agencies wanted volunteers, and then they took a decision that they did not want volunteers anymore. And so, of course, I think I was not involved at the time, but I think that was unfortunate. But we do have navigators, which are now all paid roles, mostly attached to not-for-profit organizations and government. It's working pretty good. Their funding was cut by 90% about a year ago. And so I have very grave concerns about what's going on with that. And of course, today we're going to have what I would call more like a demonstrative vote than a real vote in the House about extending enhanced premium tax subsidies. So I think I can easily imagine the SHIBA program getting drawn back into that space again, which I think is a healthy space for us. But I'd want to have like a really good charter conversation about what the boundaries are like for that. Yeah, you're 100% right. Your memory is spot on. Okay, I'm gonna run out of time, but let me just super quickly just say the last thing that I want to check in with you about. We've talked about this a bit. I never like talking about it, but I want to acknowledge that starting January 1st, we do have the advent of this program called WISER, which you'll know is an attempt by CMS, the Centers for Medicare and Medicaid Improvement and initiatives for 17 specific procedures require, in many cases, a prior authorization for folks who are in original Medicare compared to Medicare Advantage plans. This has been super controversial, very political. Senator Murray and Senator Cantwell introduced a bill about a week ago to direct HHS to cease, not go forward. I don't think that bill is going to get a hearing. So in the short term, my pragmatic response is going to be that we're going to help support you in making us aware of any complaints that beneficiaries have, any problems that they have, navigating that system of prior authorizations. We're going to be tracking it. I'm going to be reporting it back to our leadership and back to our congressional delegation. I'm just acknowledging that for some of our clients, this is going to be a big deal, and I'm going to help you with some scripting about what to say about that. But I'm just acknowledging that it's real now. We're like a week into it, and it's something we're taking very seriously, and I'm trying to figure out how exactly to support you. So with that, I just want to, as I said at the beginning of the call, for me, my first purpose is just for you to hear directly from me how grateful I am for all of your support and your hard work. I'm very aware of the difference that you make in your communities with individual people every day, and it's an inspiration to me, and it makes me feel hopeful about the future, because I feel like we have like a living example of what it looks like when people live in community and take care of each other. And so I'm hopeful that that can be kind of a light in the darkness and guide us all forward. So I just want to end by again saying how very grateful I am to each of you and all of you. And I'm looking forward to, although it'll be challenging, I'm looking forward to the year ahead with you. Apologies, I have to hop off to another program, but thank you for being here. Thank you for some of you being here more than once. And I'll look forward to seeing you soon. But in the meantime, please keep in touch. I want to be needed by you. Okay.
Thank you.
Thanks, Tim.
Take care.
Thank you.
Thank you.
Bye.